Welcome, Mark, to our chapter 9, Consciousness and Disorders of Consciousness. And today we're going to explore how it is that the brain stays aroused and what happens when arousal is lost. This is a subject we've touched on previously, but the structures that are necessary for arousal are located in the diencephalic regions. These are parts of the brain that are inclusive of the thalamus, etc., sit atop the medulla, and these are portions of the subcortical regions that, without activation, would create brain death, or at least severe loss of consciousness. And the title for this system is the reticular activating system. So here are some structures in the reticular activating system that are necessary for you to understand. There are, first of all, familiar structures such as the spinal cord. And here you can see that the spinal cord is located just below the reticular formation, which is in pink. And then surrounding the reticular formation are structures of the brainstem that we've covered previously, including the medulla, pons, and midbrain. So the brainstem, if you remember, is that part of the central nervous system which is necessary for activation of input from the peripheral nervous system to the central nervous system, and also for projections from the cortex up here to the spinal cord. So this area that is in pink, the reticular formation, are parts of the brainstem that are responsible for the arousal of the central nervous system, particularly the areas that are located above where these green arrows project. Now, in the thalamus, which is here, located above the brain stem, you'll recall that the thalamus is responsible for projecting a large number of outputs to different parts of the cortex. So the thalamus was made up of many structures, each of them with their own specific purpose, and they project to different parts of the cortex information which is passed up through the brain stem. In order for that information to be accessible to the cortex, then the reticular activating system, the formation here, needs to be intact. But unfortunately, when the reticular activating system is damaged, which can happen as a consequence of stroke, particularly in the case of strokes that occur in the thalamic region, we call these intrathalamic stroke. When that occurs, the damage to the brain stem can be severe enough to lead to a loss of consciousness and arousal diminished considerably, and can be very life-threatening. In the case of the intact reticular formation, the normal operation of the reticular formation allows us to wake up. So when we awaken in the morning, that's because of the ascending and descending pathways, essentially telling us it's time to get up because of the circadian clock. And this is also a good example of our relationship to other animals on the planet. All creatures have this system of reticular formation, allowing us to become aroused and conscious, and we call that the sleep-wake cycle. So when we're ready for bed, the opposite happens. The reticular formation closes down and allows us to lose consciousness and sends us to sleep. So when it's the case that the reticular activating system is not functioning well, and could be due to a stroke or perhaps a head injury which creates some trauma in the subcortical region around the brain stem and thalamus, then we have a number of different levels of impairment which are referring to the level of unconsciousness or loss of consciousness, loss of arousal. And we often refer to this state as being in a coma. So that's a type of lay term that is known for loss of arousal and consciousness, but there are actually several grades of coma that can be measured and used to determine how well the reticular activating system is functioning. So for example, if we had a set of tasks such as obeying commands, feeling pain in a particular area, localized pain, being able to localize pain to the leg or arm, flexion withdrawal, so this is that classic ability to be able to remove or manipulate the flexion of the hand, and extension, so flexion and extension, being able to basically operate like this and like that with your hand, is a measure of how healthy the reticular activating system is. So if we look at a very well validated scale called the Glasgow Coma Scale, then the reason it's called Glasgow is because it was invented at a hospital in Glasgow, but it's now used around the world to measure the degree of consciousness of an individual. Then the scores that are associated with each of these different motor tasks are shown here on the left. So if a patient is able to obey commands, then they get a score of 6. Associated with that is a number of different other functions. In the case of the obeying commands, those are not measured for a 6. But if we were to say, look at localizing pain, then an additional question for the Glasgow Coma Scale would be whether the person is also oriented. So this plus this, that means, as you remember from the lectures previously, orientation refers to asking a patient where they are, perhaps what day it is, and so forth. So the ability to orient oneself correctly plus localized pain would give a score of 5. And then in the case of lower down the hierarchy, the scale, we can see that we've got to see both spontaneous opening and closing of eyes, flexion, plus there may be conversation, but it's confused. So that would be a typical score of 4, and so on and so forth, down to 1, where none of these are observable, and that's the lowest possible score on the Glasgow Coma Scale.